Our speaker following Angelica Das is none other than Dr. Susan C. Taylor. And I tell you, she is a powerhouse within the field of dermatology, the subspecialty of skin of color. And it is just my privilege and honor to have her with us today. When I was a resident, she may not know this, but when I was a resident, we were able to go to one of the annual academy. I can't even remember where I was, but it was cold. But I was walking down the main corridor. My hair was longer, and I had a gentleman say, "Susan, Susan." And I said, "I think you might have mistaken me." But I was just so honored to have even thought that I could even be Dr. Susan Taylor. But it is a pleasure to have our next speaker with us. Harvard, Columbia, and University of Pennsylvania educated physician. Dr. Susan Taylor is a Sandra Lazarus Professor of Dermatology at the University of Pennsylvania's Perelman School of Medicine. She has performed pioneering work establishing skin of color as a subspecialty within dermatology, and of note, highlight, she is the founder of the Skin of Color Society, and I tell you, she is someone that we really want to appreciate of all of the things that have been built upon that society. She focuses on advancing clinical knowledge and addressing gaps in research and education regarding skin of color populations. She's led education, policy, and research initiatives that have invigorated a national dialogue about diversity, health disparities, and skin of color related issues. Her clinical focus encompasses disorders that uniquely disproportionately affects patients of color, including alopecia, scalp and pigmentary disorders, cosmetic and appearance enhancing devices, as well as cultural competence. She's a principal investigator on numerous studies and has over 75 original publications. She is the past vice president for the American Academy of Dermatology and also a former board member of the Skin of Color Society. We welcome you today. Thank you so much for being with us. And we will build upon Angelica Das's wonderful presentation as you will present on racial limitations of Fitzpatrick skin type. Welcome.
Well, thank you very much, Dr. Allen, for that very warm welcome, and also for your insight and foresight to create this very important Skin of Color symposium. So I thank you. I would like to try to share my screen. Key question, do you see the PowerPoint or do you see my notes?
We see notes, so you'll need to duplicate the display. There you go.
Okay, terrific. All righty, so this afternoon, I will discuss racial limitations of the Fitzpatrick skin type system. This is my disclosure statement. None are relevant. I will talk about a scale that I did create, and that would be my only conflict of interest. So why are we here today and what are we discussing and why are we discussing it? Well, we know that despite skin of color patients comprising almost half of the US population, that there are gaps in how to classify the myriad of skin tones and hues of these patients. So this presentation is going to address advantages and disadvantages of the currently available systems, and also allow you to think about the development of new systems. And in my opinion, that's the most important goal for today. So our objectives are: one, to analyze deficiencies in the widely used Fitzpatrick skin type system for assessing skin type, to identify systems that describe or measure constitutive skin color in patients, and three, to evaluate elements of a new skin phototype system. So we just saw this wonderful and heard this wonderful presentation from Ms. Das, who is really helping us begin to rethink the concept of race by showing the diversity of human skin colors in her mosaics. So let's talk about the Fitzpatrick skin type system. It's the most commonly used classification system in dermatologic practice. It was created back in 1975 by Thomas Fitzpatrick, who was at Harvard Medical School. I did have the pleasure of meeting him on a couple of occasions. Now, it's critically important to realize that this system was used or developed to assess the propensity of the skin to burn during phototherapy. And originally, Dr. Fitzpatrick had only 4 classifications, 1 through 4. It was later that he added skin types 5 and 6, and they were added to include individuals of Asian, Indian, and African origin. So we already see that there's a bias towards lighter skin with 1, 2, 3, and 4 being developed for lighter skin, and 5 and 6 is really being add-ons. Now, the Fitzpatrick skin type system is strictly defined as the patient's self-report of their sun reactivity after moderate ultraviolet exposure. And it's not a quantitative evaluation of skin pigmentation. We're all familiar with these 6 categories. Always burns and never tans is type 1. Always burns and tans minimally, type 2. Burns minimally, but tans moderately and gradually is type 3. If you tan well and burn minimally, you're classified, or you classify yourself as type 4. If one rarely burns or tans deeply, they're type 5. And if they never burn and tan very deeply, always type 6. So although this system is strictly defined as a patient's self-report of their sun reactivity to ultraviolet exposures, physicians commonly predict the Fitzpatrick skin type based on one's race and pigmentary phenotypes. So Fitzpatrick is often used as a means to describe constitutive skin color and ethnicity. And there's a trend for physicians to estimate sunburn and to estimate skin cancer, and also, as we heard earlier today in Dr. Davis's talk, to estimate burning potential or adverse reactions to cosmetic procedures. And the physicians use this based on their visual inspection of the patient's appearance. And this method is known as physician-diagnosed skin phototypes. And all of us, I think, do it in our practices. So how did Fitzpatrick's system transition from describing the propensity of the skin to burn from UV light to categorizing skin color and thereby being a proxy for race? Well, it most likely occurred because there's not been another widely adopted classification system for describing skin color that can be applied to all skin types. So this is a huge gap that many people have attempted to tackle. Even when the Fitzpatrick skin type classification scale is used as intended, there are inconsistencies in its accuracy. So for example, self-reported skin types have been poorly correlated to sunburn risks, as well as physician-reported skin phototypes. So there are patients who might report that they are a skin type 6, but if you do an MED on them, you can tell that they burn. Now, although physician-reported skin phototypes have been demonstrated to correlate somewhat with race, race does not consistently correlate with objective measures of pigmentation or self-reported Fitzpatrick skin phototypes. So for example, Japanese women often self-identify as having skin types 2, but Asian skin generally is considered to be non-white. Now, Fitzpatrick skin types also have been demonstrated to correlate poorly with constitutive color and minimal erythema dose values. And we're going to go through some of that data. Dr. Fitzpatrick did acknowledge that race and ethnicity are cultural and political terms with no scientific basis. Now, self-reported pigmentary phenotypes and race are significant, but they're incomplete predictors of skin phototypes in an ethnically diverse population. And a multivariate model constructed using all independent predictors of Fitzpatrick skin type only accurately predicted the skin type within 1 point of the Fitzpatrick scale with 92% accuracy. So if we look at this study by He et al., what we see is that although there were indeed significant differences in Fitzpatrick skin type among different racial groups, the entire range of skin types 1 through 6 was observed in each racial group. So if you look at the white and the Hispanic white group, you see these individuals reported skin types 1, 2, 3, 4, 5, and 6. So all of them are reported in this particular racial group. If you look all the way on the right end of the graph, you see that people who self-identified as Black reported having skin types 1, 2, 3, 4, 5, and 6. Now, the predominant skin phototype for each racial groups were as follows. The predominant type for whites was type 3. The predominant type for Latinx population was type 4. For Asian, it was type 5. American Indians also type 5, and Blacks type 6. Now, whites and Latinx individuals were the only 2 groups reporting a considerable number of skin phototypes 1, and that was about 10%. And you can see here about 10% of those who reported skin type 1 were white or white Latino. Now, all racial groups reported a substantial number of skin type 6 phototypes. And this ranged from 5% in the white group to 45% in the Black group, reporting Fitzpatrick skin type 6. Now, a little over 17% reporting the lightest pigmentary phenotypes self-identified as skin types 5 and 6. Non-Caucasian racial groups were more likely to tan than Caucasian groups, where greater than 50% of Asians and greater than 50% of American Indians and over 80% of Blacks reported tanning profusely with minimal or no burning after sun exposure. And 11% of Blacks reported burning either moderately or very easily, which means they would categorize themselves as Fitzpatrick skin types 1, 2, or 3. And almost 40% of Caucasians reported tanning moderately or profusely, and they would categorize themselves as skin types 4, 5, and 6. So we can see that in each racial ethnic group, there is a great overlap in how those individuals self-identified in terms of the Fitzpatrick skin type system. So with all these racial ethnic groups, people identified as having skin types 1, 2, 3, 4, 5, and 6. So although skin pigmentation is primarily responsible for differences in ultraviolet-induced DNA damage across racial groups, race and genetics have also been proposed to contribute to the complex nature of the skin's response to ultraviolet damage and differences in then how individuals classify their risk for sunburn. In addition to race and pigmentary phenotypes, there are unmeasured covariants that influence Fitzpatrick skin type beyond the physical appearance, perhaps through differential expression of genes that regulate the rate of melanization and distribution, or through genes that regulate UV-induced DNA damage repair. Now, how do we use the Fitzpatrick skin type in everyday practice? There was a survey that some of my students did where they asked board certified dermatologists as well as dermatology trainees how they use the Fitzpatrick skin typing system in their clinical practice, as well as how it's used to describe race and ethnicity. And in that survey, 70% of those surveyed were board certified academic dermatologists and 30% were dermatology trainees, residents. And what we found was that 41% of all respondents agreed that Fitzpatrick skin type should be included in their clinical documentation. So 25-year-old woman with Fitzpatrick skin type 3 it presents with a chief complaint of acne, eczema, psoriasis, etc. 31% of those surveyed said that they use the Fitzpatrick skin system to describe the patient's race or ethnicity. Almost half used it to describe a patient's constitutive color, and 22% utilized it in both scenarios. So it's easy, and I think it's common that we take a look at our patient. We don't ask them their propensity to tan or to burn when exposed to ultraviolet radiation, but rather we take a look at their constitutive skin color, and then we assign them a Fitzpatrick category. So you might look at someone and say, oh, I think she's a Fitzpatrick skin type 5. So these results suggested that 1/3 to 1/2 of academic dermatologists and dermatology trainees use the Fitzpatrick skin typing system to describe race or ethnicity and or constitutive skin color. So that's how it's being used today. Now, there have been some efforts to begin to redefine Fitzpatrick skin classifications, particularly if it is used by asking the patients to assess their skin. So this particular study was conducted in India to modify the skin Fitzpatrick skin type questionnaire to acknowledge cultural behaviors. So for example, since lighter skin is culturally valued in this particular population in India, patients' experience with purposeful sun exposure were limited. So if you ask those patients, if you go out in the sun at the brightest point during the day and you stay out there for 20 minutes, will you burn? That's sort of meaningless because in general, and it's a generalization, patients don't purposefully attempt to get sun exposure. So the questionnaire was modified to remove questions on use of tanning booths as well as sun exposure. And instead, the questions attempted to use more objective questions regarding dark brown, dark or brown eye color, black or dark brown hair color, or dark brown skin color. Also, they looked at employing terms such as skin irritation, skin tenderness, itching, or skin becoming darker, as opposed to the skin being painful or burning or tanning. And the feeling was if you use those other terms, irritation, tenderness, itching, becoming darker, the patients could better identify their skin type. Now, there are several alternative skin classification models that have been proposed to improve the sensitivity and specificity in identifying patients with non-white skin or skin of color. And here we see several classification systems in this particular chart. And I've selected a few for us to review. So let's talk a little bit about the Bauman skin typing system. And Dr. Leslie Bauman from Miami defined 16 skin personalities. And she identified key skin attributes. So they included dry or oily, DO, sensitive or resistant, SR, pigmented or non-pigmented, and that is the ability to develop unwanted pigmentation, so either P or N, skin that was wrinkle prone or tight, W or T. And then she combined these results into 16 possible types. And each type's experiences could experience different dermatologic problems. And if you could identify your type, you could help prevent or institute preventative measures as well as treatment options for diseases. And here to the right, you see these 16 different personality types. So in the upper square, we see this person's skin type is dry, resistant, pigmented, and tight, not wrinkled. Let's go on to the Roberts classification system. Now, Wendy Roberts in California identified a system with 4 different features or elements, and each of these elements have corresponding values. Dr. Roberts did use the Fitzpatrick skin phototyping system, so types 1 through 6. In addition, she identified a hyperpigmentation scale that she called the Roberts hyperpigmentation scale. And it was to predict the propensity for pigmentation, where H0 represented hypopigmentation, H1 minimal or transient hyperpigmentation, H2 minimal and permanent hyperpigmentation, 3 moderate and transient hyperpigmentation lasting less than a year, 4 moderate and permanent hyperpigmentation lasting greater than a year, type 5 was severe and transient hyperpigmentation, and 6 was severe and permanent hyperpigmentation. So you would assign a Fitzpatrick phototype number, and then you would assign a Roberts hyperpigmentation value. Next was the Glogau scale, which has been in existence for many years to describe photoaging. So she used his scale where G1 represented no wrinkles and early photoaging, G2 wrinkles in motion, dynamic motion, early to moderate photoaging, G3 was wrinkles at rest with advanced photoaging, and G4 was only wrinkles and severe photoaging. So you'd select a score from the Glogau photoaging system. And finally, Dr. Roberts created the Roberts scarring scale, where S0, S for scarring, was atrophy, S1 was none, no scarring, S2 was macules, S3 plaques with scar boundaries, 4 keloids, and 5 keloidal nodules. So if you select a Fitz, an H, a G, and an S value, that would then help you determine or predict the skin's response to surgery or laser treatment, particularly in darker skin. And this was potentially to avoid harmful outcomes. There is the Lancer ethnicity scale. So this scale was developed to help dermatologists clearly assess and understand the biological function of each individual. So the skin, and they wanted to look at how the skin might react to lasers and chemo exfoliation, chemical peels, sort of similar to Dr. Roberts. And they pointed out that the skin can react to those procedures in unexpected ways due to heritage or genetics, and not just visible pigmentation. Also, they use this scale to determine and anticipate skincare products for the skin. So this scale is composed of two different components. One is to determine your skin type an hour after cleansing, and you could select dry, oily, normal, combination, or sensitive. And then you add up the 4 numbers that correspond to your grandparents' ethnicity on your maternal and paternal sides. And after you add those up, you divide the total number of 4, and that's how you find your LAS score. And you can see on the right, they assign different ratings to different ethnic backgrounds, where we see people from Central, East, and West Africa would be assigned a rating of 5, whereas those of a Nordic or Celtic background would be assigned a value of 1. So you got 4 grandparents, biological grandparents. So you add the 4 different numbers, divide by 4, and you get your score. Now, a higher score means a higher risk of adverse events to various treatments, particularly to resurfacing treatments. And the score also helps you customize a skincare products for the best results of your skin. And there were skin products that were offered as part of this scale. Several years ago, I created a scale called the Taylor Hyperpigmentation Scale, and it was to be used as a new visual assessment tool for the evaluation of skin color and pigment. And we were particularly interested in hyperpigmentation and following hyperpigmentation with treatment so you could have an objective measure of the improvement in the hyperpigmentation. So yes, it was a visual scale. It was inexpensive. We wanted something convenient to assess the skin. And as I said, we were really particularly interested in hyperpigmentation. We validated the scale and we noticed that there were intra-individual and inter-individual variations among investigator ratings for skin hue and hyperpigmentation in the validation study. And 60% of the investigators felt that they would use the scale in clinical practice to document the response to hyperpigmentation from therapeutic agents. So it was a start. The scale was never brought to market. I want to bring your attention to the Pantone Skin Tone Guide. It was created by scientifically measuring thousands of actual skin tones across the full spectrum of human skin types. And there are 110 colors that are numbered from 1Y01SP to 4R15SP. And each color represents both tone and undertone. And it was specifically formulated to be the closest physical representation of skin colors. So this library is a comprehensive visual reference of human skin tones for use in any market where skin colors are relevant. So let's turn our attention for the next few minutes to objective measures of skin color and pigmentation through different devices. So there are handheld tri-stimulus reflectance colorimeters. There are 2 in particular on the market. There's the Photovolt Color Walk colorimeter, and it assigns values to skin color with low L values reflecting darker skin and higher L values reflecting lighter skin or white skin. So an L of, like 0 through 10 would be reflective of the darkest skin tones, and an L of 100 of the lightest. There's also the Minolta chromometer that is available for use. And then there are narrow band reflectance spectrophotometers. There's a dermospectrophotometer, and it gives M values or melanin values that reflect darker skin, the higher the number. And then there's the mexameter, which I know I've had experience with, particularly when conducting certain clinical research trials. Now, there was a provocative article that was published where they looked at reflectance spectrophotometers, and they said, are these reflectance spectrophotometers really the equivalent of like a blood pressure cuff for skin phototyping? And they looked at the ability of reflectance spectrophotometry to discriminate between 6 skin phototype categories using only constitutive skin color. And they evaluated it on the upper volar arm of 353 subjects. And what they found was the device, the reflectance spectrophotometer, and clinicians' assessment of skin phototypes agreed within one Fitzpatrick skin type category in greater than 80% of subjects in each of the skin phototype categories. So, you know, there was overlap. They were pretty close between a clinician's skin phototype assessment and what the spectrophotometer determined. So the agreement between clinician skin phototype and the spectrophotometer skin phototype category increased as a function of increasing clinician skin phototype. So the darker the clinician, the closer were the human assessment and then the instrument assessment. So overall, the physician-based phototyping method tended to underestimate skin phototype 1 compared with the spectrophotometer, and clinicians overestimated skin phototype 5 compared to the spectrophotometer. In regard to the narrow band reflectance spectrophotometry, it utilizes a melanin index and an erythema index. And it has shown a positive correlation with Fitzpatrick skin type. Now, although reflectance spectrophotometry accurately identifies skin color in patients with non-white skin, it may be impractical, the authors of the paper wrote, and cost prohibitive, because this particular instrument costs between $3,000 and $4,000. At least it did when the article was written. I think it's a little less than that now, but it's not going to be practical in a general dermatology clinical setting. There were, however, good day-to-day repeatability in the melanin measurement for the mexameter as well as the chromometer, but there was poor repeatability for the dermal spectrometer. So these different instruments had different reliability, so to speak. But in general, they were on target with assessing the degree of melanin in the skin. So the next question is, can precise systems classifying skin types based on images or in person via supervised machine learning be developed? So that's the next frontier, machine learning. So can that be developed so that we can classify skin type? And I think the answer is, at this point, we don't know. But any system would need to be developed with consensus-driven variables by expert panels, and you could expand the current skin color detection research and simplify programs into convenient instruments like a smartphone to guide physicians. So it would be wonderful to be able to have a program on our phone, our Android or iPhone, to assess the color of the skin. We have to be careful with AI learning. What you get out is only good as what you put in. So a new system must involve a development process that's collaborative across multiple disciplines. We have to scrutinize it for bias, because now, like, you look at facial recognition software, we know it recognizes white men best and Black women very poorly. And that is due to bias of what you put in. And it's going to be important to over-index for images of darker skin tones. So any model's potential impact on clinical outcomes should be carefully studied before moving from proof of concept to bedside. So here's the thing. We know what we have. We know how it's used and misused in terms of classification. But what our challenge is to develop a new classification system. And on that, I'm going to open it up for your thoughts on what a new classification system should look like. And I'd like to open it up to any questions that you might have.
Thank you so much, Dr. Taylor. That was incredible. We loved hearing all of it. My name's Sonali Nanda. I'm one of the PGY2 residents at OU.
Nice to meet you.
Let me see. I don't think anyone has questions yet. Would anyone like to speak up and ask something?
I have a question.
Dr. Allen, you're muted, I think.
Hold on. No, can you hear me?
Yes.
Okay. Something caught my eye when you said it, and I just wanted to make sure I understood that in one of the studies, it showed that the physician who was rating the Fitzpatrick skin type of a patient had more accuracy if they were of a darker skin tone.
Yeah, that's what those investigators found in that particular study, which is really very interesting.
Yes.
It might speak to the fact that skin of color dermatologists might be more attuned to shades and skin hues, but it's very interesting.
Yes.
So you're absolutely right.
Yes. Or within our own families have those different shadings of colors more represented.
No, I think that's a very important point. Absolutely. So the question for all of us is, well, maybe I'll pose this question to the group. Of the different scales that I reviewed, do you think any come close to being one that we should use when we classify skin color? Or maybe I should step back a bit and say, do we need to classify skin color? And if so, why? Any brave?
I wanted to offer a comment, if that would be okay. Hi, Dr. Taylor. My name is Chelsea Hanfield. I'm a dermatology resident at Mayo Clinic. I absolutely loved your talk, and really appreciated all the different scales that you went over. I almost wonder, instead of trying to develop kind of a unified scale system, if it would be better to utilize all of these different scales, looking at photosensitivity, tendency for hyperpigmentation, propensity for oily, dry skin, formation of wrinkles, and kind of preservation of skin tightening, to utilize these scales more kind of discreetly, meaning that if we're about to prescribe phototherapy for a patient, then we should be pulling on the Fitzpatrick skin type scale. Whereas if we're more concerned about pigmentary disorders like melasma, then we should be utilizing like your Taylor hyperpigmentation scale. So if that were the case, then I think our kind of challenge as a field is to kind of advertise all of these different scales and how we should be using them, for kind of our practice, if that makes sense.
No, it does. And, what you're advocating for is what part of what Dr. Wendy Roberts attempted to do, to look at different variables that are important, be it scarring, hyperpigmentation, photo aging changes, as well as reactivity to ultraviolet exposure. So you're saying really have multiple assessments and then put them together, and that would comprise the entire person. And you might even consider a component of the Lancer scale, looking at the genetics. Any other thoughts?
This is Sarah Ash. And I actually have been challenging my residents frequently because I'm a pediatric dermatologist, and they keep reporting a visual Fitzpatrick skin type to me. And I keep asking them, why does it matter? In this particular instance, you need to give me a good reason why you're giving me that piece of information. Otherwise, I really feel like it's being used as a proxy for race. And, this whole conversation is about that. And I think it really is something that we need to keep challenging, because they have other attendings in our area who require it as part of their presenting a physical exam. And I think it's relevant when it's relevant. Absolutely. But sometimes it's just not.
Dr. Davis would say it's relevant in regard to attempting to predict hyperpigmentation, post-inflammatory, or scarring in the patients who undergo laser therapy, for example. Or someone might say, well, it's relevant if I'm going to give, PUVA to a psoriasis patient. So there are many, many different scenarios with that. The question is, there are different presentations of common cutaneous disorders, racial ethnic differences. So for example, if we just think about atopic dermatitis, for many people who self-identify as Black, for example, there's a papular variety, there's a follicular variety, there is a keloidal variety, right? So that's a case where you might want to talk about the skin color or assign a number, because there's some evidence that the darker the color, the more likelihood these other morphologies will present. So I can think of a myriad of circumstances where you would want to classify the skin.
Absolutely. But I think it comes back to, you need to be attuned to why you're doing it.
Mm-hmm.
I mean, to your point.
Why not use the Pantone? 101. 101 different categories. We'll probably get just about everybody. Why don't we use something like that?
How do we make it practical in everyday clinic?
Right.
And, none of us survey our patients. And there's studies that show that they're inaccurate themselves when they try to classify themselves as if they burn or tan, or they underestimate many aspects of that themselves. And so it can be very difficult to put together what the patient feels they are and what the physician visually says they are, based on color. And it many times it's hard to combine the two into one system, as you were trying to show. I think it is important. Many times as we do consults and our residents or attendings, we're trying to explain, and we are a visual specialty. So all of the other features of a person are described. Why not the color as well, to see how that may shape your decision making and how certain medications or certain procedures, as you were saying, may affect or impact that person. But it helps to paint the picture, if you will. But I do feel that there is also a lot of discrepancy in providers in their description, which many times it just invalidates anything that we try to do. So I think we need work on this. We need a potential, maybe a work group to hash this out.
Yeah, so about 15 years ago, under the auspices of the Skin of Color Center and the Skin of Color Society, I got together a group of about 15 dermatologists from across the globe. So they were from Asia, Latin America, Europe, Africa, here in the US. And we did months of pre-work and months of post-work, and we all got together in New York for a long weekend to try to identify a new system. So, I felt we had some of the best brains in the world and still fell short. And we're not able to produce a classification system. So it's a real challenge. It's not to say we shouldn't continue to try, but it is a challenge. I mean, do we want to have a physical depiction of skin color? Do we group those 101 Pantone colors into 10 different colors and, kind of make the average, and you walk around clinic with 10 Pantone cards? Do you want to have a app that does the same as a meximeter, a spectrophotometer that's going to spit out a number for melanin and maybe a number for erythema, and then over time we learn what those numbers mean, and we can say, oh, they are a type L20. So that's if we use some type of measuring device. The easiest would be an app on our phone that could do that. And I'm sure the technology is there, right? Do we want to create equations where we have genetic background plus self-identified propensity to hyperpigment or to scar, and then come up with an equation and a number? So, I'm just putting those different thoughts and ideas out there as different ways we could proceed or not.
Yeah, Dr. Taylor, I think that the app idea is really interesting because I know that there was a big wave of using AI to try to diagnose certain skin disorders, and they could do that based on the erythema and things that you could also punch in there as well. And it wasn't super effective because us clinicians ended up having much more just specificity through history and things like that. But I do think it would be, whenever we go into like Sephora or a beauty store, now that they have so many more colors, they just put a little identifying gun like handheld device and spit out your color and then know which foundation to match you with. They have had that for years and years, and it's only getting better. Why can't we have something like that, at least some base model, to at least say you are number X, and this is how you're going to react to these certain types of lasers. And also we could use that for different areas of their body, because I think, in the summer, certain areas may be more tan, or people just have different colors throughout their body that could help us differentiate. I think that would be the best way to do it. It would be the most individualized as well.
Yeah, so the different cosmetic companies have had spectrophotometers for many years. And then they brought it into the retail space. So that's how they, spit out your color, right? And sure, we could do something similar. Absolutely.
Thanks, Dr. Taylor. Thank you so much. This was so informative. And I'll also say that we're not even great about asking the questions we need to ask. Like that should be a baseline in what we do for our patients, for all of our patients. So because to your point that you can have people who are, who you would look at and classify as Fitzpatrick skin type 1, but actually respond very differently. And then vice versa. Really, we should be asking those questions at minimal to all of our patients. And I think that in addition to classification, knowing how they respond and actually asking them the same questions to everybody would be like a baseline expectation in a history.
Yeah, Dr. Bowers, totally agree. But, busy practice, everyone's looking for a shorthand, right? Because you don't have 20 minutes for a patient to explain what all 4 biologic grandparents, their heritage was. Sometimes they don't know, right? There's still the people were enslaved. And if you think about it, about two average American lifetimes ago, that's not very long ago. So you might not know the biology, your genetic background. So it's complicated. And then I know I can hear a patient going, well, but she was adopted and we don't know. 20 minutes later, I'm not sure we had the information we need. I'm just being devil's advocate, but thank you, Dr. Bowers. Very important point. Lovely to see you.
Dr. Taylor, I wanted to say also great talk. Thank you. And but one of the main things we have to do to get through clinic is make diagnoses. And one of the areas is erythema is such a broad, it's not a color. So you have to have a background skin color to describe what color is the erythema? Is it purple? Is it brown? Is it a rosy red? Is it a burgundy? And so that's where I see the skin types once we settle on what they are, but just so that everyone's sort of in the same ballpark where we can describe things. A resident can come out and describe, and you can walk in and expect exactly what to see, and it'd be great to have the skin type, but right now we don't have that. So I think we have to learn to describe, because that's our specialty of describing things. That's what we work so hard on, but describing what you see, and they try to be as accurate about the colors, because that will give a clue to what the skin type is until the attending gets in there to see the patient.
Lynn, let me ask you this question. I never really thought of it before until right now. 2 people can go in a room and describe a rash and describe it differently because their eyes see different things, right? Their eyes pick up, those cones, rods, whatever the heck they are in there, right? So we're assuming that everybody sees the same thing, but maybe visually we all don't have the same ability or acuity to see redness or blue or violet. Has anyone looked at that?
No, but I think it's really true. And I think that's where the experience comes in, and sort of the apprenticeship of being with more experienced doctors who can show you. Sometimes you have to show, the patient even has to say, no, this is red here. And it is, every doctor brings their own experience to what they're looking at.
I just mean like visually, technically.
No, that's what I mean, visually. Yeah, what the way it's processed in the brain.
Or having the ability. You know how people are colorblind?
Yeah.
Maybe color blindness is on a continuum. I don't know.
Mm-hmm. No, it's. Yeah, I would.
All right.
Have the browser, different colors and browsers. Red is different in different. Safari, right. Redfox, and Firefox don't have the same.
That's right.
Color red.
So,
but
Dr. Allen, are you going to get us together so we can try to figure out.
I think we need to. This is an important subject because we all have our different ways of describing even of the Fitz skin tones. And even within our own clinic, there's variations of what the residents may think a skin tone within that system is, and what a provider, or maybe it's a scribe that's actually typing it in, and based on their limited knowledge or whatever has been told to them by their provider, and then they just kind of run with it on subsequent ones, maybe not told what to put in there. But, you know, I've had, and what you and Angelica Doss has kind of said about not jumping to conclusions of a person's ethnicity based on their skin tone. And I think that many times happens even within our programs. And when I've had it where maybe I was presented with a patient and they said they're African American, and okay. And so I go into the room and they're a Fitz 6, but yet they're East Indian. And I said, what made you think they were African American? And they're looking at color alone. And so misrepresentation of a culture. And so I had gotten away from labeling someone unless you have asked them personally, what is their background ethnicity? And, you know, many times people feel uncomfortable even asking that. But I think it's important as a piece of information within the physical exam and history to know that background. And so not being afraid to ask that. And most people they are very willing to tell you about their culture and history. And it just helps to not assume something that you're not too sure of, especially based on a color.
Yes.
So, but thank you so much. This has been wonderful. I really enjoyed you here and the discussion. And yes, we can't stop. I think it's important to bring this up. You've done so much work on this issue. And I think it's time for, at least in the field of dermatology and beyond, to come up with a unified system that we all can utilize. And so let's work on that together. Thank you so much.